Welcome to another episode from the Veterinary Research Channel. Today, we delve into a crucial area of canine health, urinary incontinence. This seemingly simple symptom can arise from a variety of underlying issues, significantly impacting a dog's quality of life and creating challenges for their owners. Fortunately, the American College of Veterinary Internal Medicine, or ACVIM, has recently published a comprehensive consensus statement offering up-to-date guidance on the diagnosis and management of this condition in our beloved canine companions. This consensus statement is the result of the collaborative effort of 12 experts in veterinary internal medicine, neurology, radiology, and surgery. Their goal was to provide the veterinary community with evidence-based recommendations addressing the pathophysiology, diagnosis, and treatment of urinary incontinence in dogs. While existing review articles have covered aspects of this topic, large-scale prospective clinical trials comparing treatment outcomes are still limited in veterinary medicine. Therefore, this expert panel meticulously assessed the available peer-reviewed literature and complemented it with their collective clinical expertise using a structured, consensus-building approach. This statement aims to provide practical guidelines for managing both male and female dogs experiencing urinary incontinence due to either storage or voiding problems. It is important to remember that the information presented in this consensus statement is the responsibility of the authors. To truly understand urinary incontinence, we must first appreciate the normal functioning of the lower urinary tract, which involves both the storage and the voiding of urine. The bladder acts as a reservoir, while the urethra functions as a sphincter. The bladder wall is composed of 3 interwoven layers of smooth muscle known as the detrusor muscle, along with mucosal, submucosal, and serosal layers. Both the bladder and urethra contain collagen-rich connective tissue, the proportion of which varies depending on the specific region and the sex of the dog, influencing the structural properties of the lower urinary tract. The urethra itself has an inner layer of smooth muscle, called the internal urethral sphincter, and an outer layer of striated muscle, the external urethral sphincter. In female dogs, the bladder neck is further supported by a smooth muscle sphincter that encircles the upper part of the urethra and gradually merges with the striated muscle near the vagina. Interestingly, this smooth muscle sphincter is less developed in male dogs, being primarily located in the prostatic and upper part of the membranous urethra. However, male dogs have a thicker circular layer of smooth muscle at the bladder neck. The external striated muscle in the membranous urethra constitutes a significant portion of the urethral wall, and its circular arrangement contributes to its sphincteric function. The entire urethral sphincter mechanism, responsible for maintaining continence, comprises these muscular components along with their supporting tissues and the neural pathways that control their activity. The process of urination involves 2 key phases: storage and voiding. During the storage phase, as the bladder fills, the pressure inside increases only minimally due to the bladder wall's ability to stretch and the active relaxation of the detrusor muscle. Low-level bladder distension sends signals via the pelvic nerve to a crucial area in the brainstem called the periaqueductal gray. This area acts as a central relay, communicating bladder information to higher brain centers and receiving signals that can either promote or inhibit urine storage and voiding. Excitatory signals from a specific region in the pons, known as the pontine urine storage center, travel down to the sacral spinal cord, where they stimulate motor neurons that innervate the external urethral sphincter via the pudendal nerve. This pudendal nerve stimulation causes the urethral sphincter to remain tightly closed, ensuring that the pressure within the urethra exceeds the bladder pressure, thus maintaining continence. Additionally, pelvic nerve signals stimulate sympathetic neurons of the hypogastric nerve, which act on the bladder outlet, and pudendal neurons, further supporting the contraction of the external urethral sphincter. The hypogastric nerve ultimately leads to relaxation of the detrusor muscle and contraction of the bladder trigone, contributing to continence. The voiding phase, on the other hand, is an active and often voluntary process coordinated by higher brain centers and the parasympathetic nervous system. This phase begins when the bladder reaches a critical volume, triggering the micturition reflex through specialized sensory nerve endings in the bladder wall. These signals travel via the pelvic nerve, activating reflex pathways in the spinal cord and brainstem, passing through the periaqueductal gray and the pontine micturition center. Descending signals from this center then travel to the sacral spinal cord. Preganglionic parasympathetic nerve fibers travel via the pelvic nerve to the pelvic plexus, where they synapse on postganglionic neurons either in the plexus or within the bladder wall. The neurotransmitter acetylcholine, acting on M3 receptors in the bladder muscle, causes the detrusor muscle to contract and the urethra to relax, leading to urination. Under normal circumstances, the voluntary initiation of urination occurs when the time and place are appropriate. It's worth noting that if the bladder becomes excessively distended, the connections between muscle fibers and the detrusor muscle can be disrupted, potentially leading to a loss of bladder muscle tone. Given this complex physiology, it's clear that urinary incontinence can arise from disruptions at various points in the system. The consensus statement proposes dividing urinary incontinence into two main categories: disorders of storage and disorders of voiding. These categories can be further subdivided based on whether the underlying cause is functional or mechanical. While direct comparative studies are still needed, the statement notes that female dogs are more prone to storage disorders, whereas male dogs tend to have a more equal occurrence of both storage and voiding issues. Furthermore, certain breeds may be overrepresented in groups with specific types of urinary incontinence, such as urethral sphincter mechanism incompetence or ectopic ureters. Neurological disorders affecting the brain, spinal cord, or the nerves supplying the lower urinary tract can also lead to urinary incontinence, although these are considered beyond the primary scope of this particular discussion. While overactive bladder, a common cause of functional urinary incontinence in women, is difficult to definitively diagnose in dogs due to limitations in urodynamic testing, it is thought to be associated with urinary tract infections or advanced age in dogs, often being termed idiopathic in these cases. Disorders of urine storage are characterized by involuntary urine leakage despite a normal amount of urine remaining in the bladder after urination. Mechanical causes of storage failure often involve anatomical abnormalities present from birth or resulting from surgery or injury. Examples include ectopic ureters, where the tubes carrying urine from the kidneys bypass the bladder and empty directly into the urethra or vagina, and a short urethra leading to a bladder positioned within the pelvis. These anatomical issues can shorten the functional length of the urethra where pressure exceeds bladder pressure, making it harder to maintain continence. Functional causes of storage disorders, on the other hand, typically involve issues with the urethral sphincter mechanism, such as urethral sphincter mechanism incompetence, often seen in spayed female dogs, or detrusor instability, where the bladder muscle contracts inappropriately during filling. Disorders of urine voiding occur when there is an issue with the emptying of the bladder, often resulting in an increased amount of urine remaining after urination. These can also be classified as functional or mechanical. Functional outflow obstruction describes a situation where the bladder cannot effectively expel urine or the urethra fails to relax properly, and no underlying central nervous system abnormality is identified. This panel adopted this term to encompass such functional voiding issues. Mechanical outflow obstruction, in contrast, results from a physical blockage of the urinary outflow tract, which can be inside the urethra or bladder, within the wall of these structures, or due to external compression. Both functional and mechanical outflow obstruction can lead to overflow urinary incontinence, where bladder pressure eventually exceeds urethral resistance, often occurring when the dog is resting or after attempting to urinate. Accurate diagnosis is paramount for effective management of urinary incontinence. The consensus statement emphasizes a systematic approach, beginning with a thorough history from the client and, ideally, direct observation or video review of the dog's urination and any incontinence episodes. Understanding when the incontinence occurs, where in the house, and the dog's activities surrounding these events is crucial for recognizing patterns. Asking specific questions, such as whether the dog seems aware of the urination, how long the problem has been present, whether it was present before neutering, the dog's ability to urinate normally and empty the bladder completely, any changes in urination frequency, whether the dog is drinking and urinating more than usual, the nature of the urine stream, straining during urination, appropriate posturing, any history of neurological issues or spinal pain. Fecal incontinence, dribbling after normal urination, other lower urinary tract signs like frequent urination, blood in the urine, or foul-smelling urine, and any sense of urgency before leaking, can provide invaluable clues. For female dogs, the pattern of incontinence described in the history can often lead to a presumptive diagnosis, particularly in cases of urethral sphincter mechanism incompetence. Involuntary leakage when lying down or resting is a common presentation for this condition in female dogs. However, pattern recognition can be less reliable in male dogs due to anatomical differences. A history of posturing with a weak, interrupted urine stream towards the end of urination, along with an increased amount of urine remaining after urination, can suggest functional outflow obstruction. The consensus panel strongly recommends using a standardized canine urinary incontinence survey, or CIS, at every visit to objectively assess the severity and pattern of urinary incontinence and to monitor the response to treatment over time. Several questionnaires have been published, and the panel combined elements from these to create a single standardized survey. Following the history, a thorough physical examination is essential for all dogs with urinary incontinence. Observing the dog urinate can provide information about the urine stream, presence of straining, duration of urination, and any immediate post-urination leakage. In male dogs, obstruction in the distal urethra might cause a noticeable distension or pulsation in the perineal area during urination. The dog's posture and any signs of discomfort should also be noted, as orthopedic or neurological issues can interfere with proper posturing and lead to urine retention and overflow incontinence. The physical examination should include a rectal examination with palpation of the urethra and bladder, as well as a focused neurological assessment evaluating behavior, gait, hind limb reflexes and posture, spinal reflexes, tail tone, and any back pain. During the examination, the clinician should look for evidence of urinary incontinence, such as urine or feces on the perineal hair. In male dogs, the penis should be extruded to examine the urethral opening, and the preputial opening should be evaluated for any abnormalities that might contribute to urine pooling. Palpation along the urethra, especially near the os penis in male dogs, is important to check for calculi. Palpation of the perineum can reveal masses causing urethral obstruction. Rectal examination allows palpation of the urethra and prostate gland in male dogs. In female dogs, the vulvar anatomy should be inspected for signs like paravulvar dermatitis or excessive skin folds. The urinary bladder should be palpated to assess its position, degree of distension, presence of pain, and any leakage during palpation. The size of the bladder before and after urination should be recorded, as a large amount of urine remaining after urination suggests a voiding disorder, while a small amount suggests a storage disorder. A focused neurological examination can help identify underlying neurological causes of urinary incontinence. In dogs without obvious neurological signs, the presence of fecal incontinence, spinal pain, or an abnormal gait should prompt a more comprehensive neurological evaluation and potentially advanced imaging like magnetic resonance imaging of the spine. Postvoiding residual volume, or PVRV, the amount of urine remaining in the bladder immediately after urination, should be assessed in all dogs with urinary incontinence, particularly males. An increased PVRV often indicates a voiding disorder, whereas a normal PVRV in a dog with urinary incontinence suggests a urine storage problem. PVRV can be estimated through bladder palpation, 2-dimensional or 3-dimensional ultrasound. A PVRV between 0.2 and 1.0 milliliters per kilogram of body weight is generally considered normal, while a PVRV greater than 3 milliliters per kilogram is abnormal and indicates urine retention. Values between 1 and 3 milliliters per kilogram should be interpreted in light of the dog's other clinical signs. For accurate measurement, PVRV should be assessed within 10 minutes of urination, ensuring the dog has had ample opportunity to empty its bladder fully. Ultrasound is preferred over urinary catheterization for measuring PVRV as it is less invasive and avoids the risk of catheter-associated urinary tract infections. When using 2-dimensional ultrasound, a specific formula has been shown to be the most accurate for estimating bladder volume. Urinalysis and aerobic bacterial urine culture, or ABC, are essential components of the initial diagnostic workup for all dogs presenting with urinary incontinence and those experiencing recurrent episodes. If the urine sediment examination suggests a bacterial infection, a properly collected urine sample should be submitted for quantitative ABUC and antimicrobial susceptibility testing. Alternatively, a rapid cage-side test for bacteria in the urine can be performed, and if positive, a sample should be sent for ABUC. While classic signs of a urinary tract infection include frequent urination, straining, blood in the urine, and pain during urination, associations between bacteriuria and urinary incontinence have been reported in both dogs and women. In many cases, the urinary incontinence itself may impair the body's defenses against infection, leading to bacteriuria. If the ABUC is positive for bacterial growth, the consensus statement recommends administering antimicrobials, ideally based on the susceptibility test results, for 5 days and monitoring the dog's urinary incontinence for improvement. This treatment duration is based on guidelines from the International Society for Companion Animal Infectious Diseases. If clinical signs persist after treatment, further diagnostic testing and the use of the Canine Urinary Incontinence Survey are recommended to identify the underlying cause of the incontinence. It is also recommended that a urinalysis and ABUC be performed before any interventional urinary procedures. If infection is present, antimicrobials should be given before or at the time of anesthesia. Post-procedure antibiotics should be tailored to the individual dog, the specific procedure, and any clinical signs. Urodynamic testing, which includes procedures like urethral pressure profiling, cystometrograms, leak point pressure measurements, and electromyography, is generally not considered necessary for the initial evaluation of most dogs with urinary incontinence. However, these studies can provide valuable information in cases that do not respond to initial treatments. Urethral pressure profiling can assess the pressure within the urethra, while cystometrograms evaluate bladder function during filling and emptying. Leak point pressure measures the pressure at which urine leaks, and electromyography assesses the electrical activity of the muscles involved in urination. The diagnosis of urethral sphincter mechanism incompetence, the most common storage disorder in dogs, is usually based on the dog's history, physical examination findings, and response to medication. However, if other conditions such as ectopic ureters are suspected, urodynamic testing might be considered. Studies suggest these tests can help identify concurrent functional abnormalities in dogs with ectopic ureters and potentially predict the outcome after surgical correction. Cystometry can be useful in evaluating bladder muscle abnormalities like detrusor instability. Before performing a cystometrogram, a urine culture should be obtained, and any infection should be treated with appropriate antibiotics. Standardized equipment and protocols, including anesthetic regimens and bladder fill rates, are crucial for accurate urodynamic testing and interpretation. Anesthetic agents can affect the measurements obtained. While urodynamic studies can offer valuable insights in refractory cases, their practical application is often limited by availability and the need for standardized anesthesia. Diagnostic imaging plays a significant role in evaluating the urogenital anatomy and identifying conditions relevant to urinary incontinence. The primary imaging techniques include radiography, with and without contrast agents, fluoroscopy, and ultrasonography. Survey radiographs are essential for ruling out mechanical causes of voiding disorders, such as bladder or urethral stones, mineralized lesions, or abnormalities of the os penis in male dogs. Radiographs should include the entire pelvis and perineum, and in male dogs, the pelvis and hind limbs should be positioned to visualize the penile urethra adequately. Retrograde urography, which involves introducing contrast media into the urethra and bladder and vagina/vestibule in females, is recommended for dogs suspected of having voiding disorders. This technique helps outline these structures and can provide information about a short urethra, bladder hypoplasia, patent uricus or vesicourethral diverticula, fistulae, and other abnormalities. Abdominal ultrasonography is a reasonable non-invasive screening tool for dogs suspected of having ectopic ureters and can also identify other upper urinary tract issues. While ultrasound can visualize the ureteral jets entering the bladder, allowing assessment of their presence and location, it may not detect all ectopic ureters. Therefore, cystoscopy is the preferred method for definitively diagnosing ectopic ureters. In urology, particularly cystoscopy, is a valuable tool not only for diagnosing ectopic ureters, but also for evaluating the lower urinary tract in dogs with refractory storage disorders. Cystoscopy allows direct visualization of the urethra, bladder, and ureteral openings, facilitating interventional treatments such as the administration of urethral bulking agents or the ablation of ectopic ureters. Cystoscopic ablation, using lasers or electrocautery, is the preferred treatment for intramural ectopic ureters in both male and female dogs. This minimally invasive procedure has shown promising results with potentially fewer complications compared to traditional open surgery. During cystoscopy, abnormalities of the vaginal vestibule, such as vestibulovaginal septal remnants, may be observed. While a direct causal link between these remnants and urinary incontinence has not been definitively established, the consensus statement suggests that they should be ablated during cystoscopy whenever possible, especially during ectopic ureter correction. In male dogs with storage disorders that haven't responded to phenylpropanolamine, cystoscopy can be considered before starting testosterone treatment to confirm normal lower urinary tract anatomy and rule out partial urethral obstruction. Treatment for urinary incontinence in dogs should be tailored to whether it is a storage or a voiding disorder and the specific underlying cause. If a definitive diagnosis cannot be reached after thorough evaluation, a treatment trial can be initiated and the dog's response carefully monitored. For urethral sphincter mechanism incompetence, medical management is often the first line of treatment. In female dogs, alpha-agonists such as phenylpropanolamine or estrogen compounds like diethylstilbestrol or Estriol are recommended as initial therapy. In male dogs, an alpha-agonist like phenylpropanolamine is the recommended first-line treatment. Alpha-agonists work by stimulating receptors in the internal urethral sphincter, increasing its tone, while estrogens may increase the responsiveness of these receptors and have beneficial effects on the urethral sphincter mechanism. While both alpha-agonists and estrogens can be considered initial treatments in female dogs, the panel notes that many prefer phenylpropanolamine. A minimum of 28 days is usually needed to assess the response to phenylpropanolamine. For female dogs that do not respond to phenylpropanolamine, Estriol is often the next choice. While one study did not find a synergistic effect between phenylpropanolamine and estrogens, some anecdotal evidence suggests a potential benefit in combining them for dogs that don't respond to either drug alone, or it might allow for lower doses of each. Estrogen treatment can have side effects such as mammary and vulvar swelling, uterine stump enlargement, and attractiveness to male dogs, often depending on the dose. Bone marrow suppression has also been reported with certain estrogen formulations or high doses. Side effects from phenylpropanolamine, like agitation, loss of appetite, or elevated blood pressure, and from estriol generally resolve when the medication is reduced or stopped. The use of estrogen in young, intact female dogs is generally discouraged due to potential risks to the uterus. For castrated male dogs with urethral sphincter mechanism incompetence that do not respond to phenylpropanolamine, treatment with testosterone is recommended after excluding other causes and confirming a normal post-void residual volume. Injectable testosterone cypionate or oral methyltestosterone can be used, and some studies have shown positive responses in a subset of male dogs. It is important to monitor systolic blood pressure both before starting and periodically during treatment with phenylpropanolamine, as hypertension is a possible, though uncommon, side effect. Phenylpropanolamine can increase blood pressure by affecting norepinephrine levels. Estrogen compounds might be considered as a first-line treatment in dogs with pre-existing hypertension or other conditions that increase their risk. For dogs with urethral sphincter mechanism incompetence that do not respond to medical management and have normal findings on cystoscopy and urine culture, interventional or surgical procedures can be considered. Urethral bulking agents, injected cystoscopically into the proximal urethra, can be an option. While over 80% of dogs may initially achieve continence with these agents, incontinence often recurs within a year. Various bulking agents are used in human medicine, and some have shown promise in canine studies, though currently, only one is readily available for veterinary use in the United States. Autologous skeletal muscle progenitor cell therapy is another emerging option that may be used alongside medical treatment, but it is technically challenging and not widely accessible. In older female dogs refractory to medical treatment, injectable bulking agents may be preferred due to their less invasive nature, although their effectiveness might be limited in dogs with concurrent anatomical issues. Surgical placement of an artificial urethral sphincter, a percutaneously adjustable hydraulic cuff placed around the urethra, is another option for medically unresponsive cases. This procedure has shown good to excellent long-term continence rates in a significant percentage of dogs. However, it is an invasive surgery requiring follow-up adjustments, and potential complications include urethral obstruction. Urethral sling procedures, common in human medicine, have been reported in a limited number of female dogs and may become a more viable option in the future, though they require specialized training. Surgical implants carry a risk of postoperative infections and biofilm formation. The consensus group recommends administering intravenous antibiotics before anesthesia in these cases, but routine postoperative antibiotics are not advised without documented infection. Failure to achieve continence after artificial urethral sphincter placement can be due to mechanical issues with the device or anatomical abnormalities. Contrast injection under fluoroscopy can help diagnose mechanical failures. For ectopic ureters, medical management is not effective. Cystoscopic ablation is the preferred treatment for intramural ectopic ureters in both male and female dogs. This involves using lasers or electrocautery to create a new opening for the ureter within the bladder. Studies suggest that cystoscopic ablation may have fewer complications and less recurrence of incontinence compared to traditional surgical reimplantation. The goal of the ablation is to reposition the urethral opening within the bladder, approximately 1 to 2 centimeters from its original location. Failure to achieve this can lead to ongoing incontinence. Extramural ectopic ureters, which are less common, require surgical correction involving transection and reimplantation of the ureter into the bladder. For detrusor instability, where the bladder muscle contracts inappropriately during filling, a therapeutic trial of oxybutynin, an antimuscarinic medication, is suggested for dogs that haven't responded to standard urethral sphincter mechanism incompetence treatment and have a urination pattern suggestive of detrusor instability. Empirical treatment with oxybutynin and careful monitoring of clinical signs may be reasonable given the limited availability of urodynamic testing to definitively diagnose detrusor instability. Treatment of voiding disorders depends on whether the underlying cause is functional or mechanical. For functional outflow obstruction, often seen in middle-aged, large-breed male dogs, the recommended initial treatment involves an alpha-antagonist, such as tamsulosin or prazosin, often combined with a skeletal muscle relaxant, like diazepam or alprazolam. These medications aim to reduce urethral resistance by relaxing the smooth and striated muscles of the urethra. Monitoring the response to treatment involves client communication, observing the urine stream, and measuring the post-void residual volume. In cases without chronic bladder overdistension, medications to increase bladder contractility, such as parasympathomimetics, might be considered if there is evidence of bladder atony, but their effectiveness is not well established. Anti-inflammatory drugs or glucocorticoids are not routinely recommended unless there is evidence of secondary urethral inflammation or pain. If a bacterial urinary tract infection is present, antimicrobials may be considered initially, but long-term use is generally not warranted if the voiding disorder does not improve. For dogs refractory to medical management, urinary diversion procedures might be necessary. Mechanical outflow obstruction requires addressing the underlying physical blockage. Common causes include urolithiasis, bladder or urethral tumors, proliferative urethritis, urethral strictures, foreign bodies, blood clots, and prostatic disease. Treatment strategies vary depending on the cause and location of the obstruction and may involve surgical removal of stones or masses, balloon dilation or stenting of urethral strictures, or laser ablation of tumors. Temporary urinary catheters or percutaneous cystostomy tubes may be needed to relieve obstruction and stabilize the dog. Follow-up after relieving the obstruction should include assessment of urination, post-void residual volume measurement, and repeat laboratory tests to monitor for any electrolyte or acid-base imbalances. If the post-void residual volume remains high, treatment for functional outflow obstruction should be considered. The consensus statement also addresses the role of gonadectomy or neutering in the context of urinary incontinence. For female dogs in breeds at higher risk for urinary incontinence or prepubertal females already experiencing incontinence, it is recommended to delay ovariohysterectomy or ovariectomy until after at least the first heat cycle. The timing should be tailored to the individual dog, considering breed, intended use, environment, and temperament. While current evidence does not suggest a similar delay for neutering in male dogs, the panel recommends that intact male dogs with voiding disorders be neutered to help reduce prostate size and prevent androgen-related issues. Some studies have suggested a link between neutering and the development of acquired urinary incontinence, particularly urethral sphincter mechanism incompetence in female dogs, although the evidence varies. This risk appears to be more pronounced in larger breed dogs. However, many studies have not found a strong association between the timing of spaying and the risk of developing urinary incontinence. Regular follow-up and monitoring are crucial for all dogs with urinary incontinence. The routine use of the Canine Urinary Incontinence Survey is recommended for objectively tracking improvement or regression over time. Any adverse effects of treatment should also be recorded. Dogs that do not respond well to treatment should be reevaluated for other underlying causes or concurrent conditions. Factors contributing to relapse might include poor owner compliance, drug resistance, development of other health issues, or an initial misdiagnosis. Looking towards the future, the consensus panel emphasizes the need for continued research to better understand the underlying mechanisms of urinary incontinence in dogs and to conduct prospective controlled clinical trials to compare different diagnostic and treatment approaches. Further studies are needed to determine optimal drug dosages and efficacy for conditions like urethral sphincter mechanism incompetence and functional outflow obstruction. as well as to identify factors that can predict treatment response and risk of relapse. Understanding urinary incontinence in male dogs, including its causes and treatment responses, warrants further investigation. Prevalent studies of storage and voiding disorders in male dogs will aid in diagnosis and empirical treatment strategies. The hope is that this consensus statement will stimulate future research and greater interest in this important area of canine health. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.